We'll start with the first lecture, first topic. On a lighter note, we always laugh when we hear fish in the water is thirsty. So our talk is almost about these thirsty fish. And Dr. Sagar Barasara, he is endocrinologist and is going to deliver on unquenchable thirst and elusive cause.
First of all, good evening to all the respected seniors and dear colleagues. As a opening batsman, I would like to thank APR family, secretary, my seniors, as a Nilesh sir, as a scientific secretary head, giving me the opportunity to present the few cases. These two cases are close to my heart because when I started practice 2 years back, these physicians have faith in me and they have referred these two cases to me. Both cases were presented as a polyuria. So when we are managing the case of polyuria, it is always a question: egg first or chicken first, polyuria first or polydipsia first. So this is always a question. So whenever we are evaluating the first cases to confirm polyuria, adult urine output more than 3 liter, pediatric children 2 liter per meter square, and polydipsia is water drinking more than 3.5 liter per day. So whenever we are evaluating, we need to rule out the solute diuresis versus water diuresis. So solute diuresis like diabetes. For this, the initial workup, we need to do the serum sodium, urine osmolality, 24 urine volume, potassium for hypokalemia, hypercalcemia, and glucose to rule out the diabetes. So next, if the urine osmolality is very low, then it is a water diuresis. If serum urine osmolality is very high, then it is a solute diuresis. And sometimes we need a water deprivation test, but most of the cases we can identify clinically. So without wasting time, I will start the first case. This was a case of 38-year-old gentleman. He is already diagnosed hypothyroidism and taking 75 microgram of thyronome for last 3 years. And he had symptoms of polydipsia, polyuria for last 3 years of 10 to 12 liters per day. He was used to these symptoms. He was never evaluated, but as we know, sometimes religious belief overcome the scientific belief, and he was not able to perform the Ramadan. That is why he was referred to me. And he had a history of reduced libido, and there was no other significant past history. Blood pressure was normal. Pulse was 108 per minute when I examined him. Dry tongue, skin texture was reduced. So as per the approach, I investigated. Sugar was normal, calcium was normal, potassium was normal. Serum sodium was high, serum osmolality was very high, 345, and urine osmolality was 105. So being a very sodium was very high. For this sodium, body needs to conserve the water, and the kidney was not able to conserve the water, so that is why that was the polyuria. So this is clearly a case of water diuresis. And we investigated, and at that time he had a central FSH/LS were low, testosterone was low, so it was a case of central hypogonadism. He was already on thyronome, so we cannot differentiate whether it was a primary hypothyroidism or it was a secondary hypothyroidism. So he was at that time, the free T4 was on little bit on lower side and TSH was not a little bit on higher side. Prolactin was normal and anti-TPO antibody was negative. So at this point, I started put a provisional diagnosis of lymphocytic hypophysitis, which is usually most common diagnosis in such kind of cases, and central diabetes insipidus and central hypogonadism with hypothyroidism. I started the treatment and advised the MRI. Thyronome 100 mcg dose was increased due to the high TSH, and Minrin was started and testosterone injection was advised. So patient responded very well. But as I discussed, this was the first month of my practice, so maybe I was not able to convince the patient to do the MRI on same visit. But I advised him, and he was lost to follow for almost 6 months. But after 6 months, he convinced to do the MRI, and this revealed the pituitary thickening, stalk thickening. This is the reference normal pituitary stalk, and this is the normal thickening of the stalk. So this was a case of hypophysitis, and there was a pituitary bright spot was also absent. Sorry. This is a pituitary bright spot, and this is absent in this our cases. So this is a classical case of central diabetes insipidus. This is in coronal section, and while evaluating this MRI, we found one space-occupying lesion in the deep lobe of parotid gland. So initially, we thought of some infiltrative disease like IgG4 disease or something else. So we did the routine workup, but ANA, AC level, IgG4 level, beta HCG, all were negative, all were normal. There was no any other symptoms or also present. I advised them to do the further workup, and he still refused, and hormonal replacement was continued. After 6 months, he was convinced to do the USG for this parotid lesion, and at that time there was a mass of almost 5 centimeter in the parotid gland, and he was subjected to FNAC from this parotid gland. Initial FNAC didn't give the conclusive evidence, but there was a histiocyte present in this FNAC. So again, true cut biopsy was done from this lesion, which revealed the histiocytes were present, and the IHC marker for histiocytes were also present. CD68 were also positive, and S100, CDA1, and Langerhans was positive. So the final diagnosis, so we put a diagnosis of Langerhans histiocytosis, and for further classification, we did the PET scan. It revealed the hypermetabolic lesion in the parotid gland, bilateral cervical mediastinal nodes, and also thyroid gland was also involved. And there was no FDG active disease elsewhere in the body. So this confirmed our diagnosis of Langerhans cell histiocytosis. Again, the patient was advised the treatment. For that, he consulted oncologist at Mumbai, and he did a FNAC from the thyroid lobe also, which also confirms the presence of histiocytosis in the thyroid. So it was a primary hypothyroidism due to involvement of histiocytes, and BRAF mutation was positive. He was given a 2 cycle of vinblastine, and post chemotherapy PET scan reveals the slight reduction in the lesion, but it didn't completely resolve. So again, almost 1 year he again stopped the treatment because there was steroid-induced diabetes. He lost 5 to 7 kg of weight. It was very uncomfortable experience for him, and maybe due to away from the hometown, he might not be able to convince. They are not able to convince the requirement of the further treatment, and he refused the further chemotherapy, and he stopped the treatment for almost 1 year. Again, he presented with the uncontrolled diabetes, and we re-evaluated the patient. Hypophysitis is still slightly reduced, but symptoms were not relieved, so central DI is still there. Repeat PET scan revealed the progression of disease. There was involvement of cervical spine besides the previous lesion of parotid gland, thyroid gland, and mediastinal nodes. So this is a progression of disease, and patient is further advised the chemotherapy of clarithromycin and cytosine arabinoside. So this is a case of Langerhans cell histiocytosis, and further chemotherapy is planned. Langerhans cells are mostly, these cases are seen in pediatric population, and this is a myeloid series neoplasm which usually arise from the dendritic cells. This is a very rare case, and the diagnosis was not apparent at the beginning, but it revealed after the few months. So similar kind of second case. This case was referred to me and rheumatologist simultaneously. For rheumatologist for mechanical back pain, and for me to evaluate the polyuria. First evaluated by the rheumatologist, and there was only component of mechanical back pain. There was no any other significant history to evaluate further. So when I evaluated the patient, there was a history of polyuria of 6 to 8 liter. No other complaints. Libido was normal. He is married, having a children. Weight of 121 kg. BP was 100 by 72. Pulse was 96. We cannot always go by book. We cannot do the water deprivation. But urine output was so high, so I asked him to stay in my OPD for 4 hours, and we will do the investigation after the 4 hours. So after 4 hours of fast, he was dehydrated. He was so thirsty. So at that time, I took the sample and we evaluated. Sugar was normal, calcium was normal, potassium was normal, HbA1c was 5.7, just pre-diabetes state. Again, the sodium was 146, osmolarity was 330, urine osmolarity was 104, which is very, very low for this sodium. So again, this was a case of central diabetes insipidus. So initial investigation revealed the thyroid axis was normal, gonadal axis was normal, cortisol and prolactin all were normal. So again, we did the MRI at the initial phase. So this is the optic chiasma. This is the stalk. Pituitary stalk was thickened, and similarly there was an absence of pituitary bright spot. So this is again classical finding for hypophysitis, and this time we did all the routine workup initially, like to rule out sarcoidosis. ACE level was done, IgG for subclass was done, which was slightly high, 2.44, and ANA level was done, which was negative. So IgG level is slightly high, but there was no any other clue or any tissue presentation, any other organ infiltration was present at that time. So it is said that if only IgG4 is red, that doesn't mean it is IgG4 related disease, and IgG4 related disease may present with the normal IgG4 level also. So we at that time MRI brain and spine was done. The spine was the only mechanical component was there. There was no any infiltrative lesion. USG abdomen doesn't reveal only fatty liver. Pancreas was normal, and so the initial provisional diagnosis was again lymphocytic hypophysitis was put there, and we started the treatment. So the provisional diagnosis was obesity, lymphocytic hypophysitis, central DI, and normal other axis, pituitary axis. Patient was started on Mindrin, and this, different to last patient, this patient has a recent onset of symptoms. These symptoms were only for 3 months. So to prevent the involvement of other pituitary axis, we started the pulse methyl prednisolone, and after that he was shifted to oral prednisolone. Patient responded so well that the urine output reduced to 2 liter for next 6 months. No, there was no complaint. Rest of the pituitary axis remained normal, and the oral prednisolone was gradually tapered and stopped. So after 6 months, he started developing recurrent boils and recurrent skin lesion. It is all over the body, but most of the time he developed this lesion over the nape of the neck. And he was treated for, he had taken almost 10 course of antibiotics, linezolid, each and everything. But he doesn't responded. And that is the time, sometimes we know that best diagnosis may be done outside the clinic, or maybe sometimes we have a thought outside of the clinic. So at that time, me and my rheumatologist friend were discussing this case, and at that time wisdom prevailed that he was developing lesion only and only after the course of steroid. When the steroids were stopped, after that he started the developing the lesion. So this might be inflammatory nature. It is not an infection. It might be inflammatory nature. So we thought of doing a biopsy from this lesion. So this biopsy was done. It revealed the fibrofatty tissue with moderate mixed inflammatory, including the plasma cell. This was not sufficient to confirm the presence of further IgG4 subclass antibody. And IHC was performed, and that confirmed the presence of IgG4 infiltrate, and it confirmed our diagnosis of IgG4 related disease presented as a hypophysitis. So again, he was started on immunosuppressant form of prednisolone and azoran. He is responding well, and there was no further progression of hormonal or any IgG4 related disease. So here, in these two cases, I would like to conclude that the initial imaging and hormonal evaluation may be inconclusive, necessitating the longitudinal follow-up with repeated imaging and clinical monitoring. Progression of disease or emergence of systemic feature over the time can provide the critical diagnostic clue, highlighting the importance of maintaining a broad differential diagnosis in idiopathic DI. And most of the time, histopathological confirmation remain the gold standard, especially when the imaging suggests the pituitary stalk thickening or mass lesion or biopsy is feasible. And most important thing, in last case, as my friend has helped me to multidisciplinary approach, including the endocrinology, radiology, pathology, oncology, and rheumatologist will, it is essential for accurate diagnosis and management for this. So thank you so much for patience listening. Thank you so much.